burden. And I thought it would be an amazing idea if all of us could support Riley uh, in giving some feedback and appreciation for the work that she has done in the last couple weeks. Uh, so, with that, Riley, would you like to go ahead and introduce yourself and get started on the presentation?
Yes, thank you, Sid. One second, let me share my screen. All right, can everybody see the slides okay? All right, awesome. Good morning, everyone. Like Sid already said, my name is Riley Gerardo, and I'm a senior studying biology and minoring in global health at Cornell University. This past summer, I had the opportunity to work with GEMINI as part of my global health minor, and today I'll be presenting on a small part of that project, which I've been working on with Sid, looking at the burden of emergency and operative conditions in India, a state level retrospective analysis from 1981 to 2021. In 2023, at the 76th World Health Assembly, the World Health Organization passed Resolution WHA 76.2, also known as the ECO Resolution, mandating a global strengthening of emergency, critical, and operative care. This resolution, and those that have continued to build on this more recently, play a critical role in global health as eco care accounts for more than half of the deaths in low and middle income countries, and a primary reason for this large burden is due to poor accessibility to eco care. As I'm sure you all know, quality research is a key part of improving healthcare systems. It serves to identify existing weaknesses and barriers to care, guiding policy and reform such as that recommended by the World Health Organization. To this end, a study assessing the global burden of emergency and operative conditions was published by Wimmer et al. In January of 2025, and they found a high global burden of both emergency and operative conditions, clearly demonstrating the need for further research on eco-care. Emergency medicine as a specialty was only just recognized by the Medical Council of India in 2009, making it a relatively new part of the healthcare system in India. Despite several new policies and improvements made to the field over the past several years, research shows that emergency and operative care in India is still lacking in quality and accessibility. More specifically, disparities in workforce density and access to care in rural areas are known problems in India's healthcare system. For these reasons, we chose to expand on Wimmer et al.'s study by specifically looking at the burden of emergency and operative conditions within India and evaluating the burden of emergency and operative conditions not only over time, but also geographically across different Indian states and union territories. Because deaths in Dalis are a key global health outcome, we chose to use these as our overall measure of emergency and operative conditions burden. So we aim to analyze the burden of emergency and operative conditions in India over time and across states. For this study, we collected data from the Global Burden of Disease 2021 study. The GBD 2021 study is a collection of estimates for 459 health outcomes and risk factors from 204 countries and territories, which are validated by a panel of collaborators from over 167 countries. Specifically, we gathered the estimated deaths in Dalis for emergency, operative, and emergency operative conditions in India, spanning years of 1981 to 2021. We pulled estimates from a total of 31 Indian states and union territories, and we also collected the population estimates for these states and union territories. Our definitions and classifications of emergency and operative conditions were those from previous validated literature, which used Delphi consensus to classify each condition in the GB database into the following condition groups. First, emergency conditions were defined as those frequently resulting in disability or death if not treated within hours to days. 30 emergency conditions were included in our analysis. Secondly, was operative conditions, which were defined as those potentially requiring care from a surgical provider, and we included 57 operative conditions in our data. And finally, emergency operative conditions were those falling under both the definition for emergency conditions and the definition for operative conditions. Notably, conditions classified as emergency operative were counted towards the burden for all three condition groups, not just the burden of emergency operative conditions. And there were 7 emergency operative conditions in our study. We calculated 3 different outcomes from our extracted data. All of our data was grouped by location, year, and condition group for these calculations. And just a quick note that the equations on the slides are for calculations from death, but we used the same process to calculate the same outcomes for DALYs. And so the first outcome was the total burden, and this was calculated as the sum of deaths or DALYs caused by each condition in a given condition group. Next, we calculated the percent of all-cause mortality or DALYs by dividing the total number of deaths or DALYs for that condition group by the total number of deaths or DALYs from all causes, and then multiplying by 100%. And finally, we calculated the death or DALY rate per 100,000 people by dividing the total number of deaths or DALYs in a given condition group by the population number and then multiplying by 100,000. So overall, emergency conditions accounted for an estimated total of over 4.8 million deaths in India during 2021, which accounts for 41.65% of all-cause mortality. The death rate due to emergency conditions for India in 2021 was 346 deaths per 100,000 people, and there were an estimated 196 million DALYs lost in India due to emergency conditions in 2021, and this comprised 36.98% of all-cause DALYs lost. The emergency conditions DALYs rate was 13,862 DALYs per 100,000 people in India in 2021. Operative conditions resulted in an estimated total of over 2 million deaths in India in 2021, which constitutes 17.23% of all-cause mortality. The death rate due to operative conditions for India in 2021 was 143 deaths per 100,000 people. There were more than 91 million DALYs lost in India due to operative conditions in 2021, which accounts for 17.2% of all-cause DALYs lost. And the operative conditions DALYs rate was 6,448 DALYs per 100,000 people. Emergency operative conditions contributed to an estimated total of nearly 1 million deaths in India in 2021, which comprises 8.51% of all-cause mortality. The death rate due to emergency operative conditions for India in 2021 was 71 deaths per 100,000 people. There were an estimated 50.5 million DALYs lost in India due to emergency operative conditions in 2021, accounting for 9.53% of all-cause DALYs lost. And the emergency operative conditions DALY rate was 3,571 DALYs per 100,000 people. So for brevity, I'm only going to present a select few of our visuals with a particular emphasis on mortality findings. However, as I'll discuss later on, we did find several consistent patterns across all condition groups for both deaths and DALYs. So the first figure on the left illustrates the trends in the national mortality rates for India over time, with each line representing one of our desired condition groups. Overall, the mortality rates for all 3 condition groups decreased over time. Notably, the mortality rate for emergency conditions decreased the greatest over time, although it also started significantly higher than the mortality rates for operative and emergency operative conditions. And then the figure on the right is similar to the one on the left, but it shows the national DALY rate instead of the mortality rate. And the DALY rates for all three condition groups decreased over time, with the greatest decrease in the emergency condition groups, just like we saw with the mortality rate. Right. And this heat map illustrates the trends in mortality rates for emergency conditions, both across locations and over time. We can notice again that the death rate due to emergency conditions generally has declined over time in India. In contrast, the death rates in two Indian states, Goa and Kerala, notably increased over time rather than decreased. And then of the states whose death rates did decrease over time, Punjab's death rate decreased the least overall. In contrast, the death rate in Uttar Pradesh, Jharkhand, Madhya Pradesh, and Bihar experienced some of the largest decreases over time. And the death rate due to emergency conditions in many states also appears to either show minimal change or even increase slightly over the past 10 to 20 years. And some examples of this include Nagaland, Maharashtra, and the Union Territories, excluding Delhi. If you compare the values in a single row, you can visualize the states with the highest and lowest death rates at a given time. For example, we can see that in 2021, Mizoram, Arunachal Pradesh, and Meghalaya have some of the lowest death rates due to emergency conditions, whereas Tamil Nadu, Kerala, and Odisha have some of the highest death rates due to emergency conditions in India. This heat map illustrates the trends in mortality rates for operative conditions. Although the national mortality rate due to operative conditions decreased over time, there are several states that clearly deviate from this pattern. The operative conditions mortality rate in Kerala, Mizoram, Goa, Uttarakhand, Union Territories, excluding Delhi, and Himachal Pradesh increased over time. And the operative conditions mortality rate in many states also increased and decreased several times and reached a peak mortality rate after 1981. For example, Punjab increased to a peak in 1991, then decreased, then increased again, and finally decreased again. The death rate due to operative conditions in many states, such as Mizoram, also appear to either show minimal change or even increase slightly over the past 10 to 20 years. In contrast, the mortality rate due to operative conditions in Jharkhand, Bihar, Tamil Nadu, and Uttar Pradesh showed some of the largest decreases over time. And in the row for the year of 2021, we can see that Uttarakhand, Kerala, and Tamil Nadu have some of the highest mortality rates due to operative conditions, while Jharkhand, Delhi, and Bihar have some of the lowest mortality rates due to operative conditions for 2021. This map illustrates the emergency operative conditions mortality rate in 2021 across each Indian state and union territory. It is plotted in a divergent color scale centered on the national mortality rate due to emergency operative conditions for India. So those falling below the national average are in blue, and those above the national average are in red. Unfortunately, the data collected for the Union territories excluding Delhi had to be excluded from the map. Of the remaining 30 locations, 10 of the states had mortality rates above the national average, and 20 states had mortality rates below the national average. In Uttarakhand, Tamil Nadu, and Chhattisgarh had some of the highest mortality rates due to emergency operative conditions in 2021. And in contrast, Meghalaya, Delhi, and Nagaland had some of the lowest mortality rates due to emergency operative conditions in 2021. So overall, the death and DALY rates generally decreased over time from 1981 to 2021 for emergency conditions, operative conditions, and emergency operative conditions. There were, of course, some exceptions to this trend. The mortality rate for emergency conditions in both Goa and Kerala increased over time. The mortality rate for operative conditions in Himachal Pradesh, Uttarakhand, Mizoram, Goa, and Kerala increased over time, while the mortality rate for operative conditions in Gujarat was the same in 1981 as it was in 2021. And the mortality rate for emergency operative conditions in Goa increased over time. Our results indicate that the burden of emergency and operative conditions and improvements in emergency and operative care have not been equal across all Indian states. Tamil Nadu, Chhattisgarh, and Uttarakhand had some of the highest mortality and Delhi rates across all three condition groups. Delhi, Meghalaya, and Nagaland had some of the lowest mortality and Delhi rates across all three condition groups. Kerala and Goa consistently showed some of the smallest decreases in death and Delhi rates over time for all three condition groups, whereas Jharkhand and Bihar consistently experienced some of the greatest decreases in death and Delhi rates over time for all three condition groups. However, it is important to note that the consistently small decreases in Goa's death and Delhi rates could be due to the fact that Goa consistently had one of the lowest death and Delhi rates in 1981 to begin with for all three of the condition groups. Finally, mortality and Delhi rates in many states became more stagnant or regressed over the past 10 to 20 years. Some examples of this could be seen in Himachal Pradesh, Punjab, Rajasthan, Karnataka, and Kerala. Of course, there are several limitations to our study, the first of which is that all of the data collected from the GBD 2021 study are estimates. Although GBD estimates are rigorously tested and validated, they still may not be entirely accurate in capturing the true number of deaths and Delhis for the conditions we were interested in or for our locations of interest. Another limitation, which I mentioned when discussing the map visual, is that the GBD study grouped together all union territories excluding Delhi as one location. So this limited our ability to compare the results for union territories to those of other states. Additionally, the definitions we used for classifying emergency conditions and operative conditions were very broad and likely overestimated the burden of emergency and operative conditions. For example, our definition of operative care included conditions that were often treated surgically, but could also be treated non-surgically in some cases. In the future, it could be helpful to collect data directly from hospitals, so only cases that were surgically treated are included in the burden of operative conditions. Finally, despite our interest in eco-care as a whole, we did not include an estimate of the burden of critical conditions in this study. The GBD database lacks specific data on several of the conditions, such as sepsis and mechanically ventilated patients that are generally accepted as critical illness syndromes. Thus, we felt it would not be able to accurately capture the burden of critical conditions, and we chose to exclude it from this analysis. The findings of this study have several important future implications. First, our data will be added to the Data Innovation Program Implementation and Community Action, or DIPICA dashboard. This will be key in expanding upon the existing data in the dashboard, providing a broad expanse of data that can be used for the evaluation of operative care in India. It could also be useful to expand on this data with a future study, including data on critical conditions. As I just explained in the previous slide, we decided to exclude critical conditions from our study due to a lack of data in the GBD study, but it could be extremely helpful to evaluate eco burden in India. One way we could do this is by choosing a group of participating hospitals in India to submit data on hospital admissions, but this could pose a challenge in limiting reporting bias and finding a sample that's representative of India as a whole. And another way this study could be expanded on with future studies is by conducting a similar analysis of emergency and operative care in other countries. For example, it could be interesting to compare the findings from this study to one done in a high-income country such as the US. In Wimmer et al.'s study on global emergency and operative burden, they found that Southeast Asia and Oceania consistently had some of the highest emergency and operative mortality and daily rates in the world. So it would also be interesting to look at the emergency and operative burden in a specific country in Southeast Asia and Oceania. And then here are my references in case anyone is interested. Thank you.
All right, thank you, Riley, for the presentation. Very interesting piece of work. It's a lot of data gathering and processing to get to where you're at. I love the maps as usual. When you were showing that heat map, I was writing down a comment. I gotta put that on a map, and then you showed the map, so that was great. Yes.
Thank you.
Want to open for questions? And then, Ashley, can you monitor if there's questions online?
Sure thing. First, I see that Durbrew congratulates you on a great presentation and asks, can we estimate emergency and/or operative conditions for cross-sectional data? What specific tool is used to estimate these conditions?
So we use the GBD 2021 study. I'm sure you could also try to look at like hospital specific data. But for our like comparison across states on this large of a scale, this was the easiest way to do that. I'm not sure if that answers the question fully.
I think also to add to the question, if you're trying to get to how we estimate emergency or operative conditions, if I'm understanding correctly, and as Riley had said to add, we took definition of what kind of diseases or conditions are considered emergency or operative from previous literature, and map those out after secondary databases that include how many emergency operative conditions are available. Now, I'm not sure if we did this ICD codes for this one, or we just looked at the condition names. But basically, we centered on existing sources that in the paper, we're probably we need to lay out very clearly which sources and how we define those, because there's discussion around that. So if you have cross-sectional data coming from a hospital, electronic health records or something like that, or if you do a survey to see what kind of conditions people would have in the community, you could still use these sources to flag them as emergency or operative. But it's always an operationalization of the concept. There's going to be criticism to that every time.
Yeah, to add on to Joao's point, Marcus had a related question, Riley, which is, can you give an example of one of the most common conditions that would have been in that group?
Yeah, so I can remember off the top of my head, one of ours that we saw a lot was appendicitis, which fell under all three condition groups because it was emergency operative and then also emergency operative. But yeah, like Joa was saying, we pulled from past data and all of those had tables that listed specific conditions and how they were classified. So that's how we made that delineation.
I put mine in the chat. This is Charlotte. I was curious, like, what additional data was within there on like the breakdown of the demographics of people? Like were they, thinking about kids versus teens versus older adults as they experience injuries, if patterns or burdens changed, or if you were able to tell if patterns or burdens changed in various groups, or if that was like beyond the scope.
We did not include that in our study, but I think that would also be a future direction we could take the data in. I know the GED data can be like stratified by age, so that is something we could look at in the future, but it was not something we were focused on for this.
Okay. Yeah, I see Sid comment that so you only use it ICD.
Riley, great job on doing this, especially as a senior. I mean, you should just pat yourself on the back numerous times. Put this on your fridge or something, because this is hard data. You were crystal clear in the presentation, so well done. When you go to write this up in a manuscript, I would definitely highlight that it's GBD 2021, which means that the data was collected pre-COVID. Because most global health people will know that India was one of the hardest hit countries in COVID. So that's where mine initially went when I saw the date. This is a COVID predicament, but it's not because of how the data was collected. So I would, ham that up. And then the overestimate part, can you go to the table where it showed the numbers?
Yes.
Excellent. I love this table. I also love the formulas in the previous slide. That the overestimate, and I know you pointed to this in your limitations, but for something to be 40% of total deaths and then 37% of all DALYs, I think that's going to be hard getting past a reviewer. So I would do everything you can to underestimate that, like appendicitis, or actually that's not a bad one. This is me trying to talk clinically. For the conditions that could be operative, but not always, maybe do 50% of that subset to underestimate. I'm not sure what else you can do, but this caught me not in the best of ways, that you probably are overestimating significantly here. So I would go back and look at some of your data analysis, and then maybe you did, but put parameters of a confidence interval around it.
So Emily, can you elaborate a little bit? Why do you think that this caught you in a wrong way?
Yes, mainly because 37% for something to be 37% of all total DALYs, that I've just never seen that actually. Like the third of total, even with HIV, TB, and malaria, the big three, when you total those up, that's definitely not even a third of all total DALYs. And I wonder if one of the reasons, the GBD, for better or for worse, when someone dies, you can only be counted as one condition. Pamela and I are running into this with our analysis too. So with the emergent conditions, it makes sense that this would be a significant burden all DALYs, but I think it's overestimated because they're only considered death to emergency conditions.
That's what I was thinking. Yeah, go ahead, Catherine.
Let me say that everybody dies of an emergency presentation of some condition.
Right. Yeah.
That's what happens, right? Like, unless you are made DNR and comfort care, you end up having an emergency presentation before death. So this does not surprise me at all, and I actually think it's low because people end up having a heart attack because of their cardiovascular condition, or they end up having a pneumonia and then it becomes sepsis because of their lung condition. This number actually is low to me, in my sense.
I think it really hinges on what the conditions are, right? Yeah.
Yeah, that's the discussion. I think Catherine brought a point that because it's heavily on people die, and they almost always die from the emergency things. It might bring up the burden, which is very different than talking about burden from a primary care setting or a disease that has more treatment but targets a bunch of people. So it's an interesting discussion. think about ways to have scenarios sit where we have more overestimated or more underestimated, and then bring that discussion in, might be interesting. We also might want to go into the literature of people that looked at emergency conditions from this DALY's perspective and see what their arguments were.
Yeah, because it makes me wonder, like, yes, like an MI is an emergency, a heart attack is an emergency built on a chronic condition, right? But when I originally looked at emergency condition, I was thinking of like road traffic accidents and
Yes.
things like that. And so I think like where,
Which would fall into it as
yeah,
well.
so like really clarifying the definition of an emergency condition, because there's definitely emergency on chronic sort of as like a key driver for a lot of death.
Yeah, but it brings down the point that if it's chronic, but it gets acute and it becomes an
Yeah.
emergency, then you need an emergency scenario to place that. So
Yeah,
it doesn't mean that a 37% is independent from whatever the percentage was from chronic. There's an overlap.
no, yeah, I think it just needs to be laid
that's
out, because
exactly
like where
that-
your mind goes as a
Yeah.
reader or reviewer
Yeah.
might be very different depending on what you're like including.
Or even on on just discussing that number very
Yeah.
clearly. But it points out to the argument that we're very biased to say that emergency medicine is very needed and important. So that's something to think about. Yeah, but a great discussion.
When I think about it this way, I wonder what happened to the others 50, 58%, whatever it is. Like how did they die? Because nobody dies slowly, right? So I think we need a lot of description of what that emergency condition is. I agree with the discussion completely.
Great points. All right.
Everyone else is dying peacefully of old age.
Or in their sleep. We'll go with that.
Yeah.
I
No,
mean, like-
that's
Oh, well,
it's
it's not
definitely
that.
not happening in
This-
India.
This is DALY's though, it's not that.
That's true, that's true.
So people that die from an older age, even on an emergent scenario, but they die, then there's less burden.
But the all-cause
It's both,
mortality.
Joao. It
All-cause
has deaths
mortality.
and tallies. There's both.
Yeah,
Okay, you mean the 41, okay,
Yeah.
42.
Yeah.
58, I see that now, okay.
I will say all this is really useful, by the way. So thanks so much, because Riley is right now working on the discussion of the manuscript. So I'm hoping that this kind of like goes into her draft right now. I will say though, just for context, that kind of like among like the top 5 causes in India, especially among young people, it's road traffic crashes and suicides right now. And both of those fall under emergency. So I think road traffic crashes and suicides alone contribute to like 40-50% of deaths among young people. And so even for DALYs, then, yeah, if the life expectancy is 75 and or like a huge chunk of your 25-year-olds are dying in road traffic crashes, yeah, those contribute to like 50 DALYs, yeah, just by like YLL, right? So it's probably also that. But we can look more into description around this in the paper. And Emily, I agree with you. We'll definitely add like a sensitivity analysis to show if switching some of the condition groups, if that changes this number significantly.
So Sid, to add to your discussion then, if you think that there's a big difference in the demographics, age specifically, I think you have to include that as well in this project, not a future one, because I agree with you that injuries are going to cause a huge component of that DALY, but I think you're going to have to make it an argument to the reviewers, who would be Emily, right? To be able to say all of this is coming from these specific things, and that's going to be age differentiated, which is why the DALYs will be so high.
Okay, that makes sense.
And Sid, just one clarifying question. Emergency conditions, operative, and both, are they mutually exclusive?
Are they? No, I think so. Operative and emergency are not mutually exclusive, but emergency operative are kind of like the small overlap of those two.
So in other words, if something is counted in emergency operative conditions, it's also counted in those other two, right?
Yeah, in both those, yeah.
Right.
But emergency and operative are independent.
I think they are, right? Right, Riley?
Yeah.
Well,
Yeah.
but according to what you just said, if emergency operative, if everything under emergency operative is included in operative, it would also stand to reason that those same things in emergency operative are also in emergency, which would make them
Yeah.
not mutually exclusive.
Yeah, so emergency and operative are not mutually exclusive. And so it's kind of like just the overlapping like intersection of those two that's getting like included in like this third one.
But the green column is counted within the red and the blue.
Just a combination. It's interesting.
Yeah.
To that point, if they're not mutually exclusive, it would be good to show the total, because we can't tell, right? We can't tell what's the total in any of these categories if we combine
Yeah.
them. You know what I'm saying?
No, yeah, I mean,
We
because
can't
we'll be
add
double
them.
counting then.
Exactly.
Yeah.
This could-
I
this
don't know
could
if it
be a
would be
very-
worthwhile.
It might be interesting to make a Venn diagram out of this. Because a lot of this discussion, if there's a sum between those two, it starts to raise up the amount of mortality they are accounting for. It helps to paint the picture a little further up. Yeah, okay, all right, we're gonna move us over. Thank you again. I just want to take a brief moment here to also congratulate Sid for taking the mentor role. Sid started with us as a master's student, is now moving towards his PhD. He got his PhD proposal approved, so he's on the pathway now to get his PhD completed, which is great. And took up mentorship for Riley at this moment, and we can all see he did a very good job. So yeah, it's great to have you with us, Sid. Thank you, and congratulations on the work as well.
Yeah. Thanks, Rob. I kind of also kept the mustache because I was like, I cannot look like a kid when moving on to a new role. So yeah.
Yeah,
Thanks.
we'll talk about the looks later, man.
I don't hate it. I don't hate it. Don't listen to Joao.
Cool. All right, let's move on to our second segment.